Our session sponsor, Intelligent Medical Objects. IMO offers a portfolio of products that includes terminologies and value sets that are clinically vetted, always current, and maintenance-free. This aligns to providers' organizations' missions, EHR platforms' inherent power, and the evolving vision of the healthcare industry while ensuring accurate care documentation and administrative codes. Please welcome our speakers for today's session, Dr. Amanda Heidemann, Chief Medical Information Officer at CMIO Services, LLC, and Dr. Andrew Cantor, Chief Medical Officer, Intelligent Medical Objects.
Hi, everyone. I'm Amanda Heidemann, and I'm a consulting CMIO. I work with hospitals, healthcare organizations, and healthcare IT providers to help them through their digital transformation journey and help develop strategies to build the technology of the future, to get patients what they need, to be better partners in their care, to get families and caregivers involved and empowered in their care. And when I'm not doing those things, I'm seeing patients in the emergency and urgent care settings.
Hi, Amanda, and all of you listening in. My name is Andy Cantor, and as was mentioned, I'm Chief Medical Officer for Intelligent Medical Objects. I'm an internist and sort of public health doctor, done a lot of work in global health. I wear a couple of different hats, including assistant professor at the Department of Biomedical Informatics at Columbia University and the Department of Epidemiology. And I sit on the board on global health for the National Academies of Science, Engineering, and Medicine. So I'm going to lead off today, and we're going to have a bit of a dialogue back and forth with Amanda about this topic. And so I'll start first by telling you a little bit about IMO and why is IMO even involved. I've been with the company pretty much since its founding in 1994. We represent, or actually sort of coined the term of interface terminology. We provide a infrastructure for health information systems across the country to help providers capture and document clinical care. We're in over 70% of the acute care facilities and have over 500,000 physicians using us daily in the United States and across the many of the English-speaking countries. And I'm going to talk a little bit about clinical interface terminology and why it's so important to the topic that we were going to be speaking about today. So first, it's interesting to kind of take a look back and look at how the challenges in healthcare have evolved over time and sort of what the role health information systems have actually played in solving some of those challenges. And prior to clinical interface terminology, many of the health information systems were not being used by clinicians. And you'll hear a bit more from Amanda in a bit about those early days. But it really required the use of clinically friendly terminology in health information systems that allowed providers to actually use these systems and actually be able to use computers to document important aspects of patient care. But as time went on and as clinicians were starting to capture parts of the encounter and parts of the medical practice, more and more burdens were placed on them to drive different kinds of activities. So the next one that was probably most obvious was the use of standardized codes to drive clinical quality reporting and reimbursement. And so it was really essential early on to be able to not only collect the clinical documentation, but to drive these other processes that were incentivized by the HITECH Act and meaningful use. And so this is where clinical interface terminology played a really important role, because doctors just want to speak doctor. They just want to be able to document and see within the electronic health record the content that is most relevant to the care of the patient and in the way they want to speak about it. So there are many different ways to say things like heart attack with ST elevation, and that we want to be able to capture all the different ways that a clinician might want to be able to say that concept. But clinicians don't need to be coders. And so interface terminology basically takes that clinical concept and assigns it the kinds of standardized codes that are necessary for computers to actually understand what the doctor is trying to say. So these include things like the billing codes and being able to drop information for reimbursement, but also really importantly, other kinds of reference terminologies that are used for helping drive things like clinical decision support, artificial intelligence, and we'll talk a little bit more about that in a bit. But this is where we've are right now. There have been some additional challenges in the way. New coding systems have come up, introducing new payment methodologies, and new kinds of quality measures have all been introduced. And just prior to March of 2019, we were expecting this new government regulation to come in, similar to the HITECH Act. It was called the 21st Century Cures Act. And that was going to introduce a whole bunch of new regulations in improving the interoperability of health information. And I'll talk about that in a minute. But that's what we were really expecting to happen. But what we didn't expect to happen was the COVID-19 pandemic. And that really drew a lot more attention to these particular issues and made this concept of sort of population health and value-based care and looking toward sort of the future of preventing the next pandemic to the forefront and center of our activities. And it will probably be that way for the next year or two. But let me say a little bit about the 21st Century Cures Act, because this was what was happening at the time. Essentially, this is pushing forward the general principles of increasing innovation and competition within the healthcare environment to hopefully improve quality and reduce cost. There was a real focus on reducing clinician burden and advancing the interoperability of data, which is allowing data to move between systems while retaining its meaning and sort of its actionability. And then it was really trying to bring the patient back into the center of healthcare by promoting patient access. And this was where we were at, and we were anticipating that this was going to be the major challenge that we were dealing with. And so if you sort of summarize the 21st Century Cures Act, there's two main areas that was important. One was this notion of increasing the sort of ability of data to move between systems. This was kind of like hardware and software interoperability processes. And you can think of this as sort of like greasing the skids to make it easier for data to flow back and forth. But the 21st Century Cures Act also identified that there were these sociological barriers to information flowing, and that oftentimes providers or health systems weren't incentivized to share the data with patients or with other health systems. And so they actually put in penalties to prevent what was called information blocking. And so when you took these sort of the physical interoperability standards and sort of added those to increasing or decreasing the obstacles associated with information blocking, we were really anticipating that there was going to be this data tidal wave, that there was going to be lots of data flowing around within our health ecosystems, and that was going to put a significant challenge and burden onto both patients and providers. But what we really didn't recognize until it actually happened was COVID-19. And we know that what it really did was significantly up the ante on these exact challenges about data sharing and data access, and that the pandemic itself really demonstrated that although we had sort of on paper thought about many of these topics, that there really were gaps within the health information systems and what we really hope to gain out of them during such a critical time as this. And as you looked at the actual arc of the pandemic, the kinds of information we needed and the way that information was going to be used really changed over time. And initially, it was all about capturing the extent of the disease. What was, do we have enough ventilators and isolation beds available to take care of it? But then in the middle, it was really about understanding what was happening with the disease. And on, there were opportunities for learning more about the disease. There were some really awesome, spontaneous consortiums that globally that actually arose, which was really heartening. But there was real challenges as well to the health system. And I know, Amanda, you were in the midst of it, in the trenches. What was it like for you?
Yeah, definitely some challenges. And even at the beginning, just the ability to be able to report what we were seeing. So being able to capture COVID-19 as a disease state and not having to just put something like viral syndrome in the chart or document it based on the symptoms or things like fever. To get that data of the granularity that we would need to analyze it and be able to make it useful going forward. I know that was a big day when we actually got the appropriate code entered into the chart, the appropriate ICD code that we could all use to start documenting that. and use that for our reporting. But it also it accelerated interoperability in some ways, and some things that we worked on with electronic case reporting, things that organizations had struggled with in the past about reportable diseases that were just in a pilot state, and boom, they were immediately accelerated into production, and it was truly tremendous. But yeah, it really illustrated how important the data truly is.
Yes, and I think when back on the time when I think I was flying back from an international meeting at the end of the year when it was just starting in Wuhan, and realized, hey, this is going to be a problem. And so IMO was had actually interface terminology to capture the initial symptoms and diagnosis of COVID back in really in January of 2019. And so there was a real opportunity for us to begin to use clinical interface terminology to capture the level of data. But what we realize is that this kind of topic and the kinds of levels of data necessary for COVID and for what you'll be talking about in your story coming up is still needed, very much needed. So this combination of the increased physical interoperability of data, the decreased the decreased obstacles to blocking or to passing the data back and forth, and then the context of the pandemic dramatically increased the requirements on the healthcare industry to better manage data and be smarter about how we do that. Because if we really don't handle this properly at a time when providers themselves were at the breaking point, even prior to the COVID pandemic, that this tidal wave of data had a real danger of flooding the system. So some of the things that we wanted to talk about at the hospital of the future is really how can we better handle data? How can we make it more effective, and in a way make it for us to be able to actually ride this wave, use the power of the wave to actually improve the quality of care, and hopefully the standard of living, or not the way that physicians actually and other providers provide care. So I'm going to talk a little bit about, I think, from my perspective, before Amanda starts, about where we sort of ran into trouble and where we need to be thinking in the future. And as I mentioned earlier, these systems were really initially designed as sort of glorified billing machines or practice management machines. And over time, historically, electronic health records have been viewed primarily as these kind of passive data stores. The more information you could stick in there and the clinician could put in there, the better. And that there was going to be someone on the back end who was mostly responsible for deriving the value from that data. And so whether this was risk stratification or reimbursement, it was typically those kinds of things. And that the providers were really stuck because they had all the burden of doing the data collection, but they really didn't have that data available and accessible to actually take care of the patients. They were sort of blindly asked to kind of reach into this big database and pull out the right information at the right time for the right patient. And this was a real challenge and was leading to their burnout. So I'm going to talk about slightly maybe a different paradigm. And it's something that I think we can actually all arise to and be part of this hospital of the future. And that is that health information technology is actually a communication medium. And so we think about today, most of the care is actually provided not just by me alone or Amanda alone, but by a team of people working together. And so I'm entering data into the health information system as a way to communicate with all those other members of the team so they could truly understand what's going on with the patient and be able to collaborate and do the best care as possible. More and more patients are actually being included in their care and the decision making around their care. And so that, whether it's through patient portals or through things like open notes where patients are actually reading the documentation directly, the electronic health record is the way that I often will communicate directly to them, not only in the office, but how they are able to connect with that health information in between office visits and after they've left the office. And lastly, a really important point is that the EHR is really how I communicate to myself over time. And it's not that I just can't always remember what happened 6 months ago or a year ago when you were in the office, but there was a certain kind of thought process that I had in place. I had certain clinical decision in place. I was differential diagnosing. I might have been looking for particular tests to be done. And so I actually put the information into the EHR so that when I then see you again, I'll see all of that thinking plus all the additional data that my team and other information that has come into the medical record. And so this notion that the data or the EHR or the health information technology itself is not just this passive database, but it's really a way to communicate within this ecosystem and with myself in general is a really new paradigm. And the challenge is that the way data is being collected at the point of care to serve that particular reason in that particular encounter doesn't always fit the way the data is going to be used to communicate to other members of the team or to do population health or to trigger clinical decision support rules. And that data actually needs to be pulled together and aggregated from different sources. It has to be normalized so that it's the same language across all those different information systems. It really needs to be transformed into the right format to be able to serve a very particular purpose of the patient in the office at that particular time, or the public health purpose, or maybe it's the cancer registry purpose. And lastly, it really needs to be summarized and presented to the clinicians in a way that actually supports their care of the patient and not actually overburdens them. So I think if we look at this arc of time from how important clinical interface terminology was to sort of getting clinicians to actually use the system to be able to capture the data at the right level of specificity that a clinician wants, and then think about how we need to be able to start having these systems work together and those systems be more effective at leveraging clinical decision support in the future is going to be the basis of our kind of conversation going forward. So I'm going to stop there and I'm going to turn it over to Amanda. So now you can talk a little bit more about your personal experience, and then we'll come back later for some dialogue.
Great. Thank you, Andy. So as we kind of talk a little bit about my personal healthcare data journey, as a clinical informaticist, I've been involved with maintaining patients' protected health information and maintaining their data for a long time. We want to make sure that we have solid data integrity so that we can use that data downstream for a variety of different things. But it doesn't necessarily hit home until we actually go on our own personal healthcare data journey. And I don't think any of us really expect to do this. We never wake up one morning and think, oh, today's the day that I'm going to become a patient. But, I'd like to tell you a little bit about just kind of some of the different ways that this has impacted me along my career. And also, I think it's just so important to understand where we've been with the data. Where are we coming from? As Andy mentioned, with the evolution from billing systems and just trying to get the data into the vault to now we have this data, what do we do with it? How can we use it to really improve care and empower patients? I think we need to understand that past so we can inform to the future. So a little bit more about me. I've wanted to be a doctor since I was 4. One of those kids that, there's pictures of me at my birthday with my Fisher-Price doctor bag. And, but as a kid, you have limited interactions with healthcare for the most part, many of us, if we're fortunate enough to be healthy. So my first real interaction with the healthcare system started when I was in high school. And that was where I got to play the role of being the family member, interacting with healthcare and interacting with healthcare data. So when I was a junior in high school, my mother was diagnosed with breast cancer, which is, still even today, such a big diagnosis and a big change in things for patients and for their families. And especially challenging was that she was very young. So she was 44. And when I think back about, going to visits with her and trying to support her on that journey, I was part of her care team. I didn't really know that at the time. And we didn't necessarily think of families as being part of the care team and needing access to that data. But, I got to have access to the data because I was there. And I also got to witness some of the beginning stages of patient empowerment and physicians who were trying to document to help patients understand and to lay the groundwork for patient engagement with their care. So my mom had one of those doctors that would actually dictate at the desk with the patient at the room, the little micro cassette recorders that we used to have. And thinking back, that was really something. But that data was still locked up in those manila folders. So the only time it ever got utilized was either if it was being sent off for a bill, or if someone was at a subsequent visit looking into that manila folder. So, at the time too, healthcare was evolving, not just the data and the healthcare information technology, but, things like genetic testing were not common for breast cancer patients then. That was right when BRCA was being discovered and put into regular use as a gene. So, really that manila folder was just, a diagnosis, a summary of notes of how she was doing with her treatments, and then some pathology reports. So fortunately, she did very, very well with her treatment, and that motivated me to continue on, in my pursuit of being a physician. But then, as I moved on in my career, I get to experience different roles. So the next role I played in the interaction with data was as that of a medical student, and then also, got to be fortunately or unfortunately, a family member again. So during my third year of med school, I had a grandmother that was diagnosed with colon cancer. And it was kind of a surreal experience because she was being treated at the institution where I was training. So, there were certain rotations that I avoided and had to shift around for that. But as a student, you start to really understand the role of the medical records in the treatment plan, and kind of what this data might mean to me. There in the late 1990s, we were starting to have electronic health records. Mostly they were digitized versions of patient flow sheets and kind of some rudimentary problem lists. I remember thinking it was really cool that you could look up pathology reports on these green screen terminals. Thinking back, it's a little bit of a trip down memory lane, but technology really has come a long way. And Andy, I don't know what it was like for you when you started using electronic health records in your training.
Yeah, actually, I was actually pretty lucky because when IMO's early days actually involved developing electronic health records, and during my training period, I was actually able to help develop one, and so that gave me a little bit maybe more power to utilize the technology. But I clearly saw, even at the very early stages, the benefits of being able to collect data on my patients and actually be able to see it. And when I rounded on the patients, to be able to actually have it automatically summarize it on a piece of paper for me saved so much time in those little cards, that we used to keep in our pockets. But I also saw just how it distorted the interaction, right? And it was so much of a challenge through the very kind of clunky user interfaces, and even now the challenge we have of having to use a computer while I'm actually seeing the patient. So, I saw the potential, but also saw a lot of the challenges associated with it.
Yeah, I had kind of forgotten about all those cards, and it brings back some fond or not so fond memories. But
PTSD.
thinking back to from a personal standpoint, at the time there really wasn't a good way to aggregate data for the patient either. So, if you wanted a copy of your medical record, it was up to you to ask for photocopies and to take those home and maintain them. Maybe you had the ability to scan them, or maybe you just stuck them in a manila folder at your own home. But the record was still mostly narrative. And even though we were starting to get some genetic testing and other outstanding technologies for treatment, everything was still pretty siloed and locked up. So things remained the same for a long time until some different programs spurred many of us on to electronic health records. But unfortunately, the next part of my journey became not only as a family member and by then an attending physician, but also as a patient. So fast forward about 20 years. It's a very different world. In 2017, EHRs are abundant. We're all putting in all of our data, thanks to programs like Meaningful Use. We've got that tsunami of data that we're building up. But again, we don't necessarily have the ability to unlock that data, even though it's in the chart. Being able to utilize it and leverage it for clinical decision support and functions like that was still really evolving. But by this point, my mom, fortunately, had been a 27-year survivor of breast cancer, but we got that phone call that you never want to get, which is, I've got breast cancer again. And that was very interesting because now genetic testing is everywhere. EHRs are everywhere. There's all kinds of data sharing among research institutions. And one of the highest recommendations that she got was, to go ahead and have the genetic testing. And unfortunately, due to her results on the genetic testing, that meant that I became a patient due to my genes. And that was a very interesting experience. as far as trying to understand what all of that means, and then putting on my informaticist hat, trying to go back and figure out, okay, where are all these records and where is all this data, and how can I use it to better inform not only her treatment that she's getting now, but also my own treatment plan. What's my plan for the next 40 years as we work through this. And even though there's been some strategies and some fits and starts to make that data more visible to the patients and to the families and the caregivers, a lot of those opportunities like Microsoft Health Vault and some other independent third-party data aggregators, those have kind of gone away. So, now that I was squarely in this patient role, I was really motivated to figure out what I could do about this data. And that's where I got to really play the role of clinical informaticist, trying to sort that data out. So I had been to see a genetic counselor, and kind of those records were tucked away until until earlier this year, when all of this came to a head a little bit. And part of it was due to COVID, and I'll tell you about that. But in my house, I had a little folder with everything from the geneticist and my own testing and kind of the beginnings of my own patient journey. But lo and behold, here comes COVID. And as we all know, COVID delayed a lot of services for patients. A lot of mammograms got delayed. A lot of colonoscopies got delayed. And I was certainly in that bucket. So as someone who has a very high risk for breast cancer, I was enrolled in a high risk program. And my breast MRI got bumped due to COVID. So it was supposed to happen in the fall. Here comes COVID. We're having the big fall peak that we had in the fall of 2020. And so it got bumped until January. So, I go for my routine 6-month screening, and now I've got something going on. And I've got this rogue lymph node that's new on the MRI, which is, of course, abnormal because of it. And, at the time, there was some debate back in January about, could this be due to the COVID vaccine? It's on the same side as the COVID vaccine. And I think this is really where we saw the power of that data, and for organizations to very quickly be able to drive clinical care based on the data that it was at their fingertips and based on the data they could easily share. So when you've got organizations that are able to document in the patient chart, not only, hey, there's a lymph node, hey, this is a high risk patient, hey, this is a woman who had a novel mRNA vaccine within the last 6 to 8 weeks, it actually drove a revolution in clinical care around mammography, MRIs, and breast imaging. So radiologists got together, they shared information, they realized that this was probably a phenomenon from the vaccines that was leading to a lot of false positives and a lot of concern and, a lot of, emotional challenges for patients. And within a period of about 6 or 8 weeks, we had new recommendations on the table, new clinical decision support that said, if you receive a COVID vaccine, perhaps you shouldn't get a mammogram or other breast imaging for the next, 6 to 8 to 10 to 12 weeks, depending on your history, so that you have a greater chance of not having one of these anomalous values. So, it really just showed that data was king. And without having that discrete data that we could all analyze, we would have never been able to do that. We would have never been able to see those temporal relationships between the vaccines and healthcare workers, a lot of us, who are women, and these abnormal tests. So while this was unfolding, though, I was on the leading edge of this, and before we had new recommendations. So in the meantime, I get sent to a breast surgeon. When you've got a 40% lifetime risk, that's where they send you next. So I went to the manila folder and pulled out my genetic consultation from 2017. And I really got to thinking about that. And literally, that consultation doesn't live anywhere other than in a hospital chart, because it was a hospital that I had the consultation through, the hospital chart and my manila folder. So it doesn't live in my outpatient record. It's not something my OBGYN or primary care physician can see. So I pull out the genogram and I start thinking about it, and maybe I should have some different testing based on this new situation. And it really struck me looking at the genogram, and actually what you see on the slide is my genogram. So, all the color represents cancer. So we've got a little bit of it in the family. But then you look at what's in the generations following. And as an informaticist, I really think this is just fascinating, because we have the ability now to do better prediction on what's going to happen to all those people that are the white circles and squares. We can use that data to drive how we care for them, how we do surveillance, whether we start screening them earlier for certain kinds of cancers, et cetera. But it also struck me that not only do we have the opportunity to intervene, but where does that data live and how is that data going to be used? Because I'm the circle kind of towards the bottom left, and there's 2 squares below me, and those squares are my sons. So my sons need to have documentation in their chart that represents my risk, because my risk is actually their risk as well based on the genes involved. But how does that get documented? And does it get documented at a level of granularity where it can make a difference, where it can play into clinical decision support, et cetera? So I got to play yet another role in this, and got to put on my mom hat. And, this is some of those conversations you never think you're going to have with your kid. Hey, let's sit down and talk about underage drinking and genetic surveillance, because, maybe we should go have some blood drawn. And, I kind of joke about it, because sometimes when you're in these situations, humor is one of your most powerful treatment strategies, because nobody likes to think about cancer. Nobody likes to think about the potential for that. But we do need to think about getting the right information at the right place at the right time, to make it actionable, to make sure that that data is precise and make sure that it's accurate. And really, the root of all of that is having solid clinical terminology. So knowing that those family histories, it's not just thyroid cancer unspecified, which actually was what showed up on my genetic consultation for a family history element. Knowing is that thyroid cancer, a papillary cancer, or a medullary cancer, because one of them is hereditary and one of them is not. So those things are really important. And being able to get that data discrete and mapped to a terminology so it can be shared, and so that it means the right thing to the right people looking at it. So making sure it's in a patient-friendly term when I see it through a patient portal, something that I can understand, making sure that it has the right level of specificity when it goes into a clinician chart, when it gets attached to a pathology reading or something like that, where we want to know really, really how specific that data is, being able to flow that through. And I kind of have this vision of the future where you ask somebody, oh, send me that contact card on your phone, and you text it over. I have this vision of showing up at a family reunion and sharing your family history data contact card, that you could all exchange data easily, and then your relatives could put that in their personal health record or add that to their electronic health record, and then everybody has that information at their fingertips, rather than have it just be something that's anecdotally talked about at the family fish fry once a year or something like that. But my story is not unique. We hear about these things all the time. I think sometimes they really resonate with us more just because we're in healthcare and we see the power of the data and what it can do. But there's a well-known blog, Dr. John Halamka, who's a well-known physician informaticist currently working with the Mayo Clinic platform. And actually, several years ago, he blogged about his wife and her breast cancer diagnosis and their journey, and basically what he encountered as a clinical informaticist. So, Andy, I think you and I have talked about that story a little bit.
Yes, and Amanda, you really bring the whole story home on a very personal level, and so I think both your story and Dr. Halamka's story it's important to recognize that these are all real people, and it's not just this academic discussion that we're having. But I think what Dr. Halamka realized, also as an informaticist and also someone who's going to be able to go and do research, was that breast cancer is treated differently depending on what type of breast cancer you have and how far along it is and so on. And so he was luckily able to use a clinical interface terminology within his record to identify that his wife had stage 3 breast cancer, and that there were very clear consequences of that in terms of the right types of treatments and the right kinds of care protocols. And that normally, to try to get to that characterization of the cancer, like the staging or whether or not the estrogen receptors were positive or not, requires pulling together all these different data elements that are scattered across the health system. And often they're not even in the EHR, they might be in a laboratory system or an anatomical pathology report. And so by having this highly granular term, he was able to sort of utilize that to drive the specific care that his wife needed. And that's just one example of where the right sort of terminology and putting the providers back in sort of control of the underlying health information that made it possible for him to get the best care that he could for his wife.
Yeah, and I think that's at the end of the day, us as clinicians, that's what we want to do is we want to give our patients the best care possible. And, really having that knowledge and not only having all the data available to us, but being able to unlock it and use it in a way that's actionable, being able to drive clinical decision support, being able to do alerts and care plans and things that help remind us of what we need to do. Because let's face it, clinical information and scientific information, it is doubling at an exponential speed. And, we as clinicians, we can't possibly remember it all the time. And I think it's really great that we can harness these information systems and use those to prompt us to make sure that we take the right actions at the right time for the right patient, and also to help empower patients in their care. I really think that some of the new things that are evolving over the last year or so, including open notes, which really became mandatory within just the last few weeks, I think that's huge. Being able to look at your own records and even when you find something that might be concerning, being able to have that dialogue with your physician, with your care team, so that everybody has a greater understanding of the healthcare situation moving forward. It really is revolutionary. And I think there's so many good things on the horizon. Just as I mentioned, the things that were accelerated by the pandemic, electronic case reporting. I was working with a client that was struggling with that as far as reportable diseases. And now all of a sudden the door is open to that and they can manage things in different ways that they were not able to do prior to the COVID-19 pandemic. So science will continue to build on itself. Healthcare information technology will continue to build on itself. And I'm excited about it. I mean, certainly there's a lot to learn and there's a lot of work to be done, but it's challenging and very exciting work.
Amanda, I think that so much of the future, when we're looking, we get from Star Trek or some of these future shows, and it's like, are the computers just simply going to replace the physicians, and is machine learning and artificial intelligence just simply going to take over in the future, and we'll be talking to a bot instead of a doctor? And I don't think that that's likely to happen. And so all those advances that you're talking about really, in my mind, brings to a more helpful technology, one that really augments the provider. And I often talk about, it's not artificial intelligence, AI, it's really intelligence augmentation, or IA, that we're talking about here. It's how can the computers actually do things that we don't do very well, or let us know about things that we don't already know. And in that way, sort of offload a lot of the burden that we have of dealing with all of the data or the history, and let me just be the doctor, and really interact with you and do the right thing by you. I think the other thing that you guys talked about really was that the data matters as to where it actually is, and so the fact that we are all part of this big family or community, and that there is your parents' records have a diagnosis like medullary carcinoma of the thyroid or whatever, and that I am related to that person, and therefore in my record I'm either a family history of that problem, or maybe that means I'm high risk for such and such a disease. And so being able to manipulate and transform the data that's in one person's record that's related to another, and make sure the right information is in the patient whom we're seeing's chart, is going to be one of the ways that the technology of the future, I think, would really help. Sorry, I think you were going to say something. I don't.
Yeah, no, I mean, it's just, it's such an exciting topic, and talking about what you just mentioned about the family history and making sure that we know how to document that for the future generations. One of the things I look forward to is being able to use the data to help stamp that out. Let's get that documented. Let's start screening patients, sooner. And make sure that, we're not seeing colon cancer anymore because we're screening people appropriately, and making sure that we're reducing those risks. Or even as we get into things like precision medicine and genomics, figuring out, is there something specific we can do to reduce this risk and transform that risk, therapies or other modifications of lifestyle, rather than just doing surveillance. So I think there's just a huge amount of potential for the hospital of the future, and getting really the underlying solid data and solid terminology is just such a huge part of it.
I think about the challenges it is to go from, your individual sequence data that you might get from uh, a company like 23andMe, or one of your more specific hospital consultations, genetic consultations, and sort of say, well, how do I transform those ACT letters, sequences, or variant names into something meaningful to me as a patient or to as my provider that they need to know about? So, I think there's going to be a lot of exciting work that's going to be done that's going to sort of automate that process of saying, well, this particular variant leads this person to be at higher risk for this particular disease, or maybe it actually affects what that person's treatment protocols might be, because let's say that means that they're going to likely chew up or metabolize a drug faster because of that genetic composition. Therefore, you know what, to be really effective in treating this person's breast cancer, I need to double the dose, because based on their genetics, they're going to chew up that drug faster than another different person, and therefore they need a higher dose of drug. So that's where the intersection of the amazing sequencing and all that, and understanding all of these variants that are happening in the community, and also with COVID-19, for example, how those actually then translate into things that patients and providers need to guide their care. And I think about even more, one of my colleagues at Columbia was doing a lot of work on sort of sequencing the actual cancer cells now. So not only are you worried about maybe the genetic composition of your family member and through the family history, and then your own sequence and how that might affect your care or your susceptibility to disease. But now we're actually going to also have to store the genome of the actual cancer that you have in your body, because we know that certain genomes are going to be more susceptible to certain kinds of treatments and so on. So this is it's going to be a fantastically challenging future, but I think that the technology, if done properly, can help guide us through that successfully.
Yeah, certainly it's a great time to be a clinical informaticist. When I'm in the ER, you're always, laser focused on what you're seeing in front of you, but just even some of the technologies that are promising to help people like us. So often I'll work in kind of rural or more distant facilities where you don't have a radiologist on staff to read your x-rays as you're taking them. And, we saw this when COVID first hit, and you were talking about augmented intelligence versus artificial intelligence, and just some of the technology that's come out this year to look at the chest x-rays and to help do augmented readings of the chest x-rays to determine, is this a COVID pattern chest x-ray? Is this a pneumonia pattern chest x-ray? And in order for those systems to be successful, they have to not only be able to process the image, but also process the data that goes with it. So what is that granular clinical data about the patient's age, their risk factor, their smoking history, any other diagnoses that the patient has? So, I think that just really emphasizes how all that hard work that we as clinicians have done over the last decade, getting all that data into the charts, it's really starting to come to fruition, and we can really make it useful. And I look forward to the day when I have a system like that with me to help read the x-rays, as opposed to, having to call a colleague, hey, can you help me look at this film? Because really a lot of the healthcare in the United States is not delivered in academic medical centers. It's delivered in ambulatory facilities and rural facilities where this technology really can accelerate the quality of care that patients receive, and also help the physicians and care teams care for a much broader population of patients. So it's exciting stuff.
I was thinking about from my global health perspective and the COVID pandemic, and sort of helping deal not only with sort of the treatment side of things, but eventually now the prevention side of it as well, is that, how important it is for us to be able to share success stories and be able to look at our patients and our kind of care history and be able to share it with our colleagues overseas. And hopefully that level of specificity and information can really help blunt, this fourth wave of the pandemic. And whether it's identifying patients who are particularly indicated for things like monoclonal antibody treatment, or for who are potentially at high risk for having blood clots and things like that, that the technology can really help avoid a lot of serious problems in the future. And when you think about vaccines and just the tremendous effort right now that we're all going through to do that. That there's both the prospective aspect of it in terms of trying to be fair and equitable about delivery of that to the right people and the people who most need it. But after the fact, it's going to be really essential to use that health information to go back and not only make sure that people have the right kind of documentation so that they know that they're protected, but did we miss anybody? Were we fair and equitable in our vaccinations? And having the right level of granularity of the data is going to be really important for us to do that, which then leads us to preparation for the future and the next pandemic or preventing the next pandemic. I think these kinds of infrastructure, if done properly, will really set us up well for doing that.
Yeah, absolutely. And this is, fortunately, both of my children are very interested in science, and, we have some interesting dinner table conversations about this, and, thinking about what a rough year this has been. And there's been a tremendous burden on folks as far as mental health and some of the future potential complications of this, the social isolation, issues with the economy and things like that. Being able to track that data and identify those complications, identify some of those downstream ill effects before they become an issue, or get the right services to the right people. Because let's face it, even with vaccination, even as we begin to roll that out across the globe and we reduce the number of new COVID cases, some of the long-term effects of COVID will be with us a very long time. And not just the psychological effects, but also physical effects. We're starting to see the long COVID, and our local institution just set up a long haul COVID center, a multidisciplinary center to help those patients, but being able to look for tracks and trends and look for things that we don't see coming. So, for example, chickenpox, very common childhood disease. You don't realize that chickenpox is a problem until 50, 60 years later when you get shingles. So, unfortunately, if there is some sort of long stream sequela like that to COVID, something that hits us in 20, 30, 40 years, it's really going to be that population level data, that surveillance level data that helps us identify that. And knowing from the documentation who had COVID, who had immediate resolution, who got it twice, who got it post-vaccination, I think that data is all going to play in, 10, 15, 20 years from now. I think it's going to be tremendous trying to sort this out versus, where we are here today, trying to look back 20 years when that data is still sitting in the middle of folders from, the 1990s versus, 20 years from now. Think of the incredible amount of data that we'll have to tease that out. And, hopefully in, 50 or 60 years, since we're all going to live to be 100 through the promise of science and medicine, we'll be able to pull out those paper vaccination cards and, jokingly say, back in my day, we had this paper card and they wrote on it with a pen. Hopefully those will be fond memories of the past that are ultimately mitigated through technology.
I certainly hope so. And I think both of us are, feel like we're somehow helping bring about a rosier future and a more appropriate use of technology to make the world a better place, both for the patients who we take care of, as well as our colleagues who are sharing the burden. So, Amanda, this has been a great conversation. Thank you so much. I hopefully, our audience had an opportunity to take away some important lessons from this. And I'm just so grateful that you were, able to share your story, a personal story that obviously means quite a lot to you, but very much demonstrates exactly why this is such a critical topic to be talking about.
Yeah, absolutely. I'm always happy to help people understand the downstream impact of the work that they're doing and their day-to-day roles, whether you're, in a billing office or administrative office, whether you're a database analyst, whether you're building EHR templates. All of your work is really valuable to the patients. It's really valuable to the clinicians. And we look forward to much more time together making care delivery better.
That's great. Thank you.
Thank you, Amanda and Andrew, for the great conversation, valuable insights, and sharing your stories. And thank you to our session sponsor, Intelligent Medical Objects, for their support. Please stay tuned for the next session.